as Thom tells it, this episode is going to be good for you, and you will not put your foot in your mouth. Tonight we have Dr. Chris Yardan with us. How are you doing today, sir?
Very good.
Why don't you tell us a little about your training, what you've gone through to get to where you are today?
Absolutely. So I'm originally from Brantford, Connecticut. I went to Notre Dame West Haven, Boston College for undergrad, and then I went to the Ohio College of Podiatric Medicine, which is out in Cleveland, Ohio. And then I did a 3-year residency in South Florida in reconstructive foot and ankle surgery. Since then, I've been building towards getting board certified, and I've recently become board certified in reconstructive foot and ankle surgery by the American Board of Foot and Ankle Surgeons.
And you're right here in town?
Yes, right here in Wallingford.
Podiatry in Connecticut.
Mm-hmm.
Where's it going? How's it going? Is it good, bad?
I think it's good. I think that, it has been a little bit behind the times to a degree if you compare it to different sections of the country. It's kind of location dependent, and I would say over the last 5 to 10 years or so, you're seeing an influx of quality surgeons that are coming into the state and really, I believe, pushing the envelope, and not so much the surgery, I think it's always been there, but I think more of the community understanding of what podiatry is and where it's going.
General foot problems.
Well,
Better in Connecticut, worse?
I guess it depends on the season.
Really?
Yeah, I mean, there's definitely time of the year that seems to dictate some of the pathology that we see. In the summer, really, you see people who are going barefoot more, and I'm sure that probably doesn't take that much to understand that you could have more problems being barefoot with just trauma, stepping on nails or things like this, or just having bad mechanics or a lack of arch support because you're wearing your flip-flops and these other things, and then all of a sudden you start to develop foot pain, which foot pain in and of itself is a fairly general term, and it really can represent a vast array of different pathologies that we may see in an office setting.
Now, we talked before about in the sand, on the sidewalk, running on tar.
Yes.
Good or bad for you?
Well, it seems that the harder the surface that you're running on, i.e. concrete, for instance, okay, that's usually pretty bad. If you really want to get into the physics of it all, it has to do with elastic recoil and all this other stuff. But basically, the softer the surface you're running on, for the most part, is usually a little bit better for your feet and your knees up to a certain point. You can kind of pass that threshold where softness becomes a little bit too soft. And a good example of that may be the sand. If you've ever tried to run on the sand, you can see how hard that is. And sometimes you can overuse muscles when it's too soft. But a happy medium, you look at the tracks, the high schools, you look at the cross-country trails and things. Okay, they have a little give to it. Running on grass is actually probably the best. All right, and then asphalt, you see people running on. That's okay. There's actually a little give in asphalt, more than you might actually think. But concrete in general would be definitely the worst surface to be running on.
The different types of shoes don't help?
The shoes do help. It depends. You'll notice that brands have an array of shoes and shoe designs and shoe stiffness. To sit here and say one shoe is better than the other, I wouldn't necessarily say that. But I would say that depending on what's going on, a certain shoe may be better off. A lot of times, in general, their shoes are too soft. So the soles of the shoe is very floppy, it's bendable. And if you think about it, your foot has to work a lot harder when the shoe isn't stiff. The muscles inside the foot are trying to stabilize inside the foot, as well as the muscles that are in the leg that then control the function of the foot. And so the softer the surface, the more they have to work, the more they may get fatigued, the more they may break down, and you may develop different problems depending on multiple factors. But
I have a debate with somebody about socks and shoes during the summer.
Mm-hmm.
Should your feet breathe?
I think it depends. I mean, it really is a case-by-case scenario. I mean, some people will have what we call hyperhidrosis, which is you just sweat a lot, right? A moist environment can be conducive to developing fungus infections, and to be honest, bacteria only survive in a wet environment. So socks in the summer, if you're sweating and your socks are wet and your feet are wet, I would say that's bad. If your feet are dry, then I don't think that's a problem. I think the socks are okay. I think you just have to see how you're doing. I mean, there's times in the winter where some people may sweat a lot and all of a sudden they're having the same problem. They're always in their shoes, right? Because it's cold out. But then the shoe insulates quite well, and now it's a very moist environment, and it's actually conducive to either bacteria or fungus. So it kind of depends on the person. So to give you kind of not a direct answer, you kind of have to feel your foot and see, are you really wet down there, or is it a nice dry environment, at which point socks are fine.
Flip-flops, yes or no?
I mean, I'm not a proponent of flip-flops. I can tell you that I'd almost rather you be barefoot than flip-flops. There's no support there. The flip-flops themselves are incredibly soft. So they're not helping your foot structure. So you're really kind of doing it on your own. The other thing is to keep flip-flops on, you actually have to fire certain muscles. All right, you either have to bring your toes up or you have to bring your toes down in order to keep them on. And so when you're walking and you're doing that, you may actually be creating an abnormal motion that then could potentially turn into something more significant that then all of a sudden is painful consistently even when you're not walking, or maybe when you're wearing shoes now at that point.
Climbing stairs as an exercise. Good for your feet, good for your legs.
I mean, I think again, some of the people that I see, it would depend on the age. If you have someone in their 80s, I don't know if I'd love them going up and down the stairs. At the same time, you want to go up and you want to go down. You're going to fire different muscles when you're ascending and descending. So when you're going down the stairs, you're usually firing your hamstrings more. And when you're going up the stairs, you're firing your quads more. All right. You'll get your calf muscles will do that, regardless. I think for stair climbing and some of that's a lot of physical therapy. And, a lot of that's for post-op patients and things like this that we're trying to re-strengthen them so that they don't become a fall risk. And that's a big thing for me.
You got an example of how do you say it? Plantar
Plantar fasciitis.
I got it.
That's probably one of the more common things that happen in the foot, or at least everybody who has foot pain seems to think that they have plantar fasciitis. Plantar fasciitis is basically a disease of poor arch support. All right? Your arch is like a triangle. Okay? When you take a step, all right, your foot is going to flex a little bit. All right? You have the joints have a little bit of gliding motion. The ligaments have just a subtle amount of ability to stretch, just a hair. Okay? And if you can imagine your foot being this, okay, the plantar fascial band extends from the heel all the way out into the toes. Now, in the heel, it actually attaches to the bone. But out at the toes, it goes into the deep fascia. So when you take a step and your foot comes down a little bit, all right, that plantar fascial band has to go under tension. And what literally happens is the ligament is trying to rip itself off of the bone, okay, as your arch is collapsing. The plantar fascial ligament is like a rope. It's not like an elastic band. It doesn't have any stretch to it. And so the only place that it really gives, all right, is at that attachment site. Your toes will curl a little bit when you take a step. If that plantar fascial band comes under tension, it'll release that a little bit distally, or out towards the end of your foot. But back here, that doesn't happen. And so what happens is when you take that, you're not supporting your arch because you're wearing flip-flops or you're barefoot or you've gained a bunch of weight or whatever it may be, okay, you get what we would call a traction inflammation right at that spot. Now, I hear a lot of times where people say, oh, my bone spurs are acting up. The bone spur does not give you the pain. When we take an x-ray and we look at this, the bone spur gives me an understanding of how long you've been suffering with this. The body's ability to deal with inflammation in general, and that would go with this and other tendon problems where they actually attach to the bone, is the body tries to figure out how are we going to stop this inflammation. And it tries to turn the tissue to bone. That's the body's solution to try and get rid of the inflammation. And so when I look at an x-ray and I look at somebody, I've had people come into my office and they may have a very large spur right at the attachment site of the plantar fascial band and they have no pain. They came in for something completely different. And then I've had other people come in and who cannot walk and I look at their x-ray and there's nothing there at all. So it gives me this understanding of the long-term effects of this, how long this patient's, say, been suffering. Now, the plantar fascial band basically is suffering because of the arch support, like I said. So the first thing that people really need to do if they do, in fact, have plantar fasciitis from WebMD or if they Google, what they think their symptoms are, all right, is to support their arch, okay? And there's a lot of different ways you can do that, right? You go to the store, you buy something over the counter, you go to the Dr. Scholl's kiosk, you stand on there, they kind of give you your foot type. I think all of that is reasonable, okay? That could be something that may solve your problem, all right? And if it doesn't, then you may need to go to the next step of some level of insert. And the specificity of the insert, all right, really depends on the hardness of it. If you can imagine going to a store and buying a hard insert, everybody's foot is a little bit different in design. Okay, so a company that was making inserts, they can't make something that hard because it's not going to give it all. And if everybody's foot's different, there's such a small subset of people that would actually be able to tolerate that. And so what they do is the inserts tend to be softer. A lot of time that may not quite cut it for the patient. They may need something that's really going to hold that height of that arch up, all right, so that those structures can finally get a break. Now, Ice is one of the best anti-inflammatories we have. So if you're having plantar fasciitis, you ice the foot, you can take a bottle of water, you can freeze it. You know, you see some of this stuff online with the tennis ball, this, that, and the other, okay? Those all are meant to help decrease inflammation, all right? You're talking about Advil, Tylenol, obviously depending if you can take that sort of thing, if you don't have, comorbidities that may preclude you from doing that, will definitely decrease the inflammation. Treating the symptom, not the cause, okay? And then treating the cause is really that back to that arch support thing. Now, some people, I think, which is a big misnomer, is the whole idea of wearing heels. People think wearing heels is so bad. Well, it actually isn't as bad as you might think. It kind of depends on what's going on. I guess an easy rule of thumb for me is if you're having problems with the front of your foot, okay, the toes, people have heard of bunions, neuromas, okay, that means that you have a lot of pressure on the front of the foot. And I actually recommend that people wear flat shoes at that point. If you have what we call rear foot problems or ankle problems, a lot of times you actually want to put someone in a heel for that, a 2 or 3 inch heel, actually from a mechanical standpoint, that we have what's called the biomechanics of the foot. When you are in a quote unquote plantar flex position where the foot is pointing downward, okay, you are actually locking your arch height. Now, if you think back to what I said about the arch collapsing as you're walking, okay, if you're in a heel, okay, you're mechanically locking your arch and it actually can't give. So there are times where heels will actually behoove people who are having plantar fasciitis, some who have, say, Achilles tendonitis, other tendinopathies in the foot. There's several that are common. And so that's somewhat of a misnomer, I think, of the general population that come in. And I tell them, you should try wearing a heel. They look at me like, really? Wear a heel? And then they come back, sure enough, they're like, you know what? You were right. And I was like, sometimes it works.
Exotic and salvage. What are you talking about there?
Common things are common, right? Plantar fasciitis is common, all right? Tendonitis, sports injuries, even trauma to a degree is common, okay? Then you start getting into the things that aren't, the 10% or less of patients that we typically see, all right? Limb salvage, diabetes, failed surgeries, failed fusions, failed treatment of fractures of the ankle and what have you. And you bring this with diabetes as a comorbidity, with vascular disease, okay? And all of a sudden, these people that were not getting a good result from the initial surgery or had repetitive surgeries really didn't have an option, and we were amputating them above or below the knee.
How long ago?
I would say within the last 5 to 7 years, we've had a big jump in some of the technology and some of the techniques that we're using now that have afforded us more options for these patients. Not to get too technical, but when we would have a real bad situation where somebody's ankle was destroyed for whatever reason, whether it be a failed fusion, a failed surgery, multiple fractures, whatever it may be, okay, we would use these big bone grafts, okay? And, bone grafts to a degree can be good when they're your own, but when you're talking about large segments of area that aren't going to be able to be filled by your own bone, because where am I going to get a big chunk of bone from you, right? There's places we can get small chunks and we can use them, tastefully, we'll say, all right? But then there are times where there's big defects and we simply didn't have anything before. Now we have a few new options, and really that's come along with the 3D printing capability that you're seeing more and more in society today. And an example of that is right here. What I designed with some engineers from a company that basically does 3D custom implant design for orthopedic procedures.
What part of the foot or leg would that go into?
It's a combination of a couple things. It initially started as what we would call a trabecular cage, which is really just this, okay? And it started with spine surgery. And they were using these for defects in the spine. What we were doing in the foot was we were doing replacements of full bones, really in this case the talus. The talus is a bone that connects the leg to the foot, okay? And a lot of times when that talus was gone, for whatever reason it may be, we didn't have any options, okay? We would fuse your heel to your leg, and we would take the whole segment out. And now all of a sudden you had a limb that was like that much shorter, okay? And that's if you weren't infected, okay? Or if you went on to what we call a non-union, where the bones just simply do not become one. Our goal in a lot of surgeries, all right, is to fuse the bones so that they become solid. And when that happens, it usually eliminates the pain, okay? In this case, what this allows me to do is it allows me to span that defect with this. And so no longer do we get a significant shortening of your limb, okay? And you don't end up with these two odd-looking legs, okay? okay? And a lot of times when there's bone infection, we have to remove so much bone that someone may say to you, listen, it's not salvageable. We can't save your leg. We've taken too much at this point. We could try to do all this stuff, but the literature would suggest that it fails. So in this case, this is part of the talar head. This was the talar body. This still articulates with the joint. This fills the defect that was created by the failed surgery. And then we put this nail straight up the middle like that and lock it. And so for this patient, we take a CT scan, we put it on the computer, I sit on the computer with the engineers, and we basically design this whole thing from scratch.
For that particular
that particular patient, correct. And then we actually take whatever residual bone is left over that I actually have to remove to put this in, and I actually have to crumple it all up, and I have to sit there for about a half hour.
Really?
And push it all in here. Yes, this cage is supposed to have these gaps so that the bone will actually grow all the way across this, and this just becomes a scaffold for it, and eventually your bone becomes from here to here, and the whole surgery works.
And it stays in forever.
Stays in forever. Yeah, this will never. Some implants we have to take out. I tell the patients, it doesn't bother you unless it bothers me. This one, this isn't going anywhere. All right, but usually this really fixes the problem for these people. I've had 2 patients so far that I've had far enough out, 9 months plus, okay, who are totally pain-free, walking around. One of them was 74 and diabetic, okay? The other one was 52, had multiple surgeries, and was basically told there was no way to save her leg. And I convinced her that I felt like I could with this. She gave me the shot. It worked out, and she's praising me, and she really credits me for saving that.
Wow.
And, you know, I mean, that goes on. You talk about the social impact of this. I mean, you know, foot and ankle surgery in general is such an impactful surgery for people. You know, if I told you that, you know, you couldn't walk on your leg for 3 months, all right, your entire lifestyle would be different. You know, you could go have heart surgery, you know, maybe you have some other major abdominal or general surgery, and that's going to affect your lifestyle. It's going to affect your diet, right? It's going to affect maybe what you can do to a degree. But if you can't walk, you can't go anywhere, you can't drive, okay? You can't even really go to the bathroom without assistance, at least not until you really get comfortable with it. You know, you're basically now requiring assistance from the people that you love to help you the most. And so that's one thing that I'm very adamant about with patients is making sure they have a support group behind them so that we don't have to deal with things that maybe could have been avoided.
So would that relate to this?
To a degree, yes. I mean, somebody who would have this would be non-weight bearing for months. So, you know, to that degree, it's who's your friends, who's your neighbors, do you have a daughter, do you have a son, can they come? You know, we're very proactive with that, with the patients to make sure that.
So if they can handle it, you're going to be able to walk again. You're going to be whole again.
Oh, 100%. My goal is to have you 100% pain-free, ambulatory, and doing everything. Now, their ankle won't move with that because their ankle's been locked, okay? But their leg becomes a stable platform so that
Will
now
they
can
walk
go.
regular?
You would never know.
Oh, okay.
I mean, you might see a small hitch in their gait, and you might say, I wonder if they have a hip problem or a knee problem or something, because they may not be fully symmetrical, all right? But they'll be pain-free.
They don't have to get the 2 different size shoes and.
No, that's one of the advantages of this. I don't need to do that, send them to boost them to equalize their limbs. So, yeah, it's pretty cool stuff.
And let's talk about Midstate and COI.
I got on staff at Midstate back in 2016, and since then, you've had the formation of the Connecticut Orthopedic Institute, which has really just been a conglomeration of doctors from multiple different orthopedic groups. And then I obviously am in a group by myself, but I was invited to join this. And it's really been a site of excellence for orthopedic surgery. Like, there's no doubt, in my opinion, it's probably the top facility in the state doing everything from total joints to foot and ankle surgery to spine surgery and everything in between.
Would Yale say that too?
Reluctantly, I would think. Reluctantly, they would. I think
That's good. I'd like to hear that.
Yeah, well, I mean, I think what Midstate did, which I think behooved them, was that they really ingratiated themselves to the physicians. I think they kind of looked at it and said, you know, maybe we could get them on our side. Maybe if we, you know, extend ourselves to see what the physicians really want and what's bothering them, we accommodate them, that we will draw more doctors to our facility, and that's exactly what has happened.
So somebody finally listened.
Yeah, I think so.
Healthcare in Connecticut. Good, bad, medium? Where are we?
Healthcare in Connecticut. Well, I think that whenever you see a expanding Medicaid population, you always want to be a little bit concerned. Okay, because to some degree, the more people that are on Medicaid and the less people who are on private, all right, it affects the way the community health care is delivered. Medicaid reimbursements are not up to par with everything else. And what that does from a financial standpoint is you see a lot of doctors' practices simply don't take it. And then what happens is these Medicaid patients aren't given the options that they may want for doctors. And then if they're not given the options, or maybe they even call a doctor's office and they do accept Medicaid, but the appointment for Medicaid may be 3 months down the road. Okay, that patient may end up in the ED a couple times. And when I say ED, I mean emergency room. Okay, at a much higher cost. And I would never blame the patients for that. I blame the access. And the access is limited because the reimbursement is below what everything else is. And so it's kind of like a snowball effect. So when I look at the state of Connecticut, we have, I think it's like 18 to 20% of the state is on Medicaid, which, I think is somewhere around the national average or maybe a little bit above it. I think if we were looking at healthcare in general, we'd like to look at that number. And is that number expanding or is that number shrinking? Because if it's shrinking, it means that people are getting back into the work system, they're getting on private healthcare insurance, all right, and that's no longer state funded, as opposed to the opposite. When we think of, insurances in general, I don't know about everyone else, but even my deductible has gone through the roof, and I kind of look at that and wonder why. And I think that for people in general, they need to really understand their health care plan now. It gets complicated.
I'll just ask you. The insurance guys try to control you guys. It's a weird thing to say, but that's what the people are suspecting.
I mean,
you guys are being held back.
Held back, I wouldn't say we're being held back, no. I would say that if you really wanted to look at the understanding of where medicine is and now, it's a constant dance between the insurance companies, the hospital, Medicare and Medicaid, and the physicians, right? You have hospital physicians, you have community physicians, all right? They kind of operate a little bit differently. There's one salary, right, from the hospital. You see as many patients as whatever, it doesn't really matter. There's something called RVU, but we won't get into all that. And then you have the outpatient, all right, which is more of performance-based. You're in a... Well, I mean, I'm an independent physician, so there is nobody else. So for me, I just try to do the best job I can, and that should hopefully build my practice. There's a lot of money to be made in medicine. If you're asking me as a physician, do I think that, there's lots of people who are taking a little piece of the pie as the dollar bill goes from you to me? Yes. I think that the way that our system is set up now is that it encourages that to a degree. And I think if it were up to me, I would try to reduce that more so that it's really just you and me dealing with one another. And if I was to do something fraudulent, okay, a lot of people don't understand their plans. They don't understand their deductibles. They don't understand how their insurance is basically, trying to reduce the rate. So when you look at a bill, for instance, like if I give you a bill and it's for $500, you'll be like, oh my God, it's $500. And then you'll see another one, the allowed amount, right? And that's from the insurance. And then there's the patient responsibility, right? And so that all depends on, one is, has the doctor and the insurance company have agreed upon contract, which they usually do. So I'll bill $500, the agreed contract is $300. Okay, so the actual bill is $300. But now you have a $5,000 deductible. So the patient allowance, or at least the patient responsibility, is going to be the $300. But then people have primary and secondary insurances, and then understanding where those all come in. And I think just to round it out really quickly, Medicare covers 80% of your bills. And so a lot of people get the secondary insurance to cover that last 20%. But what I think most people don't understand is that just because you have a secondary insurance, once you have Medicare, all of your plan and everything follows Medicare's guidelines.
Say it again, slow.
When you go into a doctor and you want something, and they're going to say, I have Medicare as my primary and United as my secondary. All right, a lot of times they'll say, I called United and they told me that this is covered, blah, 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 blah. And a lot of times we have to tell them, yes, they're telling you that because they don't realize that that Medicare is involved. And Medicare really sets the bar in terms of what you're afforded as a patient. So it gets a little complicated like that. But to some people, I would say, understand your deductibles, understand, what you're allowed. And when you go and get a plan, make sure you tailor it. If you have eye problems, make sure you get eye coverage. if you've been used to getting foot care and getting orthotics and all this other stuff, make sure that that's covered in your plan. You have to be, I think for patients, you have to be a little bit more proactive now when shopping for insurance and understanding. And who wants to sit there and read a 100-page guideline on your plan? Nobody. So I think just having those benchmarks or earmarks is important when you go for that.
In 2 minutes, talk to me about Surgery Center in Hampton.
So there's a new surgery center. It used to be the old Hamden Surgery Center. It's on Whitney Avenue. It's been completely gutted, completely redone. We have just recently gotten the Medicare certification. We're just waiting for the official documentation. But it should be, a flagship facility in the state of Connecticut. I mean, really top notch. I mean, it's just all the top doctors, I think, got involved with this. And, it's just starting to rev up now. And I'm hoping that it's going to be a real good thing for the community, both Wallingford, Hampden, North Haven, really, the surrounding
So
county.
you're going to work there at Flush, correct?
So I do cases there. I'm on the board there. So
Now you're on the board at Meriden too, Mid-State?
I'm section chief of podiatry at Midstate. Yes, that's a title. There's no monetary, point to that.
Oh, why would why would a doctor go on salary?
That is a long discussion.
I'm going, you're
To make it very simple, the complexity of healthcare now can overwhelm doctors to the point that they got into medicine to treat patients, not to do business.
Okay.
And so unless you've got that ability to grit it out and do all the other things, whether it be electronic medical records, insurance companies, credentialing, billing, you're talking about overhead, staff, labor. I mean, this can just be too much, and you have to take care of patients at the same time.
Okay.
And so people just say, you know what, it's too complex. I just want to check in at 9, go home at 5, and do good work, but not feel like I never leave work.
Okay, that's a good explanation. And I want to thank you for coming on to the show. And you're right uptown. Everybody can find you. You're right across from the library, right? All right. Appreciate it, Doc, for coming in and talking to me.
Pleasure.
Yes, sir.
Yeah.
Welcome back to Tom's 2-Minute Tips or Less. Tonight, another one on first impression, your entrance, how you walk in. You can have a stride of either slow or fast, but make it determined. Are you large and in charge? Did they know you're the person that's looking for that job? They'll know it when they see it. Shoulders back, chest out. Know the layout of the room, if at all possible. And remember, don't sit until they do. If those tips help, I'll see you at the next one.